Okay. Hi students. So a very good evening to everyone, and we are live now. And today is a very interesting class because we are going to discuss some important video based questions in radiology. So this is very new. We have never seen such video based questions before, so it's new for even us, for the teachers, and it is new for the students as well. So but I'm sure that we'll make it very easy for you, and there can be a couple of questions that could come from radiology as in the form of videos. Practically I could say that any image can be converted into a video, right? So the point is there is no need to get scared of the videos, right? It is everything which you have already seen. You know, radiology, it is everything is image based questions, right? But if those images can be converted into videos either in the form of ultrasound, CT or MRI, I would say that there is no need to get scared from these videos. It's something which you have already seen in the form of images. So it's just their way of, to test you, maybe in the form of a long question, because you will take some more time to see the videos rather than the images. So that is something which we'll work upon. And in today's class, what we are going to do is we are going to discuss some important 10 to 12 questions in the form of videos, right? And while we'll be doing these videos, I will be also giving you a couple of questions that will be showing you the clinical vignette. So many of the questions will be such that even by just seeing the clinical vignette, you will be able to mark your answer, right? But my point is that we have to cover those particular pathologies in the form of videos, so that we are going to do. If everything is okay, if someone can just confirm that everything is okay, audio is okay, you can see everything on the screen, please give me a thumbs up, and then we'll be good to start. So what to expect in radiology? I would say that some high yield ultrasound signs and artifacts that could be tested in the form of videos. They can then show you some dynamic imaging, like for an example, they can show you barium, they can show you fluoroscopy. These are some difficography images, so they can show you investigations in the form of videos. They can ask you some integrated video based questions, and then they can give you some radiology images. Like for an example, they will give you a person with say wing beaten tremors, like in Wilson's disease, and then they can give you an MRI brain image of the Wilson's disease, right? So that is how they can test you. They can convert any image into video practically, right? Any particular image, any ultrasound image which you have already seen in your radiology lectures, that could be converted into video. But again, we will not spend so much of time on videos because the chances, the probability of these video questions getting asked is not that much, right? So we'll just cover some important signs which could be tested. And of course, so actually if you see CT and MRI, if they are just giving you some axial scrollable images, right, don't expect that they will give you some scrollables. Like some of the students reached out to me that they will give you the CT and MRI scrollable stacks. You are not yet radiologist, they will not ask you scrollable stacks, and I think I'm pretty confident that they will not ask you the scrollable stacks in CT and MRI images. Okay, so yeah, so Puneet, yes, everything is fine. Chalo, let's start with our first question. We'll read the question, then I will show you the video, and then we will discuss about the answer. That is how we are going to approach. We are going to discuss 10 to 12 questions in this particular class, and of course, we will be also uploading more and more videos on the app. These are some of the collection of videos which I had, and we are going to discuss. Again, they are important. You have already seen all these videos in the form of images. Nothing is new. Nothing is something which you have to learn again. It's just that the presentation of the question will be little different. Okay. So let's start with our first question. A 2-month-old infant presents with recurrent bilious vomiting and abdominal distension. What is the most likely diagnosis? So the question given to you is recurrent bilious vomiting and abdominal distension, and it's a newborn, 2-month-old. Okay, let's see the video. What is the video showing? So first of all, identify what is this investigation. This is the ultrasound. Right now, the ultrasound, I am telling you that the probe has been put in the epigastric region in the midline of the baby, and you are able to see this video. Now look at this video very nicely. I am going to play this video. I will be replaying the videos like 2 to 3 times. So you can see that there is some swirling type of motion that you are seeing in the epigastric region, right? Anyone wants to comment? What could this be? What sign of which particular pathology is there, which sign is depicted on the ultrasound? You can see that very nice swirling motion in a newborn presenting with bilious vomiting, recurrent bilious vomiting, abdominal pain is there, and you are able to see this. Please, someone please answer this particular sign. Okay, so I will just highlight what we are seeing over here. So what you are seeing over here is, can you see this twisting? So this twisting is nothing but it is twisting of the superior mesenteric vein. Okay, this anechoic structure, this tubular structure which you are seeing, that is nothing but the superior mesenteric vein. Yes, Ricky, very good. It's volvulus. Yes, it's midgut volvulus due to intestinal malrotation. So what we are seeing, which particular sign? We are seeing over here is the whirlpool sign. So this is nothing but this is your whirlpool sign on ultrasound. So what happens in the whirlpool sign? First of all, what happens in intestinal malrotation? We know that there is failure of counterclockwise rotation of the bowel around the superior mesenteric artery during the development, right? So because of this, the DJ flexure is not going to cross towards the left side. Okay, it will be on the right side. That will be predisposing to a very short mesentery. Because of this, the bowel is going to twist. Apart from this, what we are going to see? We are going to see an altered relationship of SMA and SMV. So in this video, what you are seeing is that this particular tubular structure, this is nothing but the SMV. This echogenic structure, this white area you are seeing, right? That echogenic structure is nothing but that is the mesentery, right? So there is actually swelling of the superior mesenteric vein as well as the mesentery around the superior mesenteric artery because of this malrotation, right? And because of this because of the shortened mesentery, it has predisposed to what? It has predisposed to midgut volvulus. So the answer over here is midgut volvulus, and this is a characteristic video that you will see whenever they will be testing you for whirlpool signs. So this is one of the signs in ultrasound where a video will play a better role as compared to an image. They can also show you a simple image in which you can see this concentric lamellated appearance, right? So that you can see. Okay. So Ashima Bhatia, she is asking that, ma'am, can you please locate this kind? Okay, so Sumit, actually what is the problem that today we are going to present in the PowerPoint, right? Because we are using videos, we are not using Notability. So that is the problem with PowerPoint, that the pen is, unfortunately, this is the best pen which we can afford in the PowerPoint. So my apologies for that. And what we will do is to resolve this issue, I will be giving you a proper annotated PDF after the lecture. Maybe in the comments we will just upload it. On the app also it would be available, but please bear with the pen. The pen is, unfortunately, because we are doing it in the PowerPoint today rather than our usual apps which we use, because videos have to be played only in the PowerPoint. So that is why the pen will be a little limitation in today's class. Okay, so again I am just replaying this video for you. So there is a lot of technical things which we are also learning because of the video based questions. So you can see over here this. Okay, I will just show you again. Okay. I'm really sorry for this. Yeah. So what you are seeing over here is that this anechoic tubular structure, that is nothing but the SMV over here. Again, it's little difficult for me to annotate on the moving video. I will just pause it and show you. That would be relatively better. Okay, so what you are seeing over here is this particular tubular anechoic structure, that is nothing but your superior mesenteric vein, and that twisting movement that you are seeing, that is the whirlpool sign. Okay, now what about the other options? Hypertrophic pyloric stenosis. What sign will you see in hypertrophic pyloric stenosis? You will see the target sign on the ultrasound, because what happens, there is a very thickened mucosa. What is the diameter of the mucosa? It's approximately 3 mm for the muscularis mucosa. That will be showing. Okay. Okay, and then what about intussusception? Intussusception, you will see that classical, they can give you a barium image, they can give you the claw sign or the coiled spring appearance when it comes to intussusception. Whereas in duodenal atresia, they will not show you any ultrasound, they will probably give you an X-ray with the double bubble appearance, right? So what are the, again, see, this is the CT image. So whatever the ultrasound video which I have shown you, Sohail Akhtar, it is very difficult for me to again replay it. I would recommend you to just rewind and just see it again, because it will take a lot of time. But in initial part of the video, I have replayed it for 2 to 3 times, so you can see it again, right? So what is this particular image? Again on the CT image, you can see this concentric lamellated appearance over here, right? Concentric lamellated appearance. If you just try to imagine, you are able to see that there is some concentric lamellate. Again, they can show you a CT scrollable stack, or they can show you an ultrasound image in which in the dynamic movement you will be able to see this whirlpooling or this swirling very nicely. Okay, so this is the sign which you will get. This is the whirlpool Whirlpool appearance. I'm really sorry. I know that the pen is a little issue in the PowerPoint. I'll try to change the color. Let's see if that works. What is there? There is an altered relationship of SMA and SMV. Is this any better? SMA and SMV. So there is an altered relation. See, what happens is normally the superior mesenteric vein, it is present medially. It is present to the right. But in the midgut, in the volvulus, what is going to happen? The SMV is going to move towards the left side. It is going to go towards the left side, and that is why we say that there is an altered relationship. Normally, medially there is SMV, and laterally there is presence of SMA. This entire relationship which is there, it is altered whenever there is a volvulus, right? And X-ray, what you will see on the X-ray, again on the X-ray, you can see double bubble appearance, okay, because the obstruction which is there, it is actually at the level of what? At the level of the duodenum. So you can give the double bubble sign. Single bubble you will see in the congenital hypertrophic pylorus, right? Another important thing which can be again tested in the form of video for small bowel obstruction is that the gold standard method. Now, what is the gold standard method when it comes to midgut volvulus? It is your upper GIT study, okay? So Sumit, thank you. So it's much better now. So upper, yeah, so the gold standard is upper GIT, barium or the fluoroscopy study, right? Okay, so what happens over here, what appearance and what particular sign that you are going to see when it comes to a midgut volvulus? You will see the characteristic corkscrew appearance. Again, as I told you that the bowel, it is going to rotate around its shortened mesentery. So again, they can show you this corkscrew type of an appearance on a barium male, right? Because the bowel which is there, it is twisting, especially the duodenum and the proximal part of the jejunum, it is going to rotate around its own self, around its mesenteric root, and that will give you the corkscrew appearance. Most characteristic sign to test on the upper GI barium study is that the DJ flexure is not going to cross towards the left, and the DJ flexure, this particular junction, the junction of the DJ flexure, it is noted to the right of the midline. That is the most important point, and I would say that is the gold standard method of testifying that yes, this is the case of midgut volvulus in a malrotation, right? So I hope this is clear. We have seen 2-3 signs. One is your Whirlpool sign, right? One important thing is corkscrew sign, but the characteristic ultrasound Whirlpool sign can really be tested, and that is why I have included that as your first question, right? So let's move towards our second question. So first I'll just read the MCQ and then I will be playing the video. I'll be replaying the video 2 to 3 times so that you can see it nicely, right? A 28-year-old primigravida at 32 weeks of gestation is referred for a detailed fetal anomaly scan after routine obstetric ultrasound, and it demonstrated ventriculomegaly and cardiomegaly. So there are 2 things. There is ventriculomegaly, they have said, and there is a cardiomegaly, right? Now, fetal echocardiography reveals that there is a high output cardiac failure. So they have told you that there is something related to heart. Now, targeted fetal neurosonography is done. So, they have done a fetal antenatal ultrasonography of the fetal skull, right? Based on the imaging findings which are shown in the video, what is the most likely diagnosis? Okay, so let us just play this particular video. So this is, again, if you are joining right now, I'm just telling you, this is the fetal ultrasound brain. Okay, what you are seeing over here, can you see this? Again, I think I am only coming in between. So yeah, this is the fetal ultrasound, and you are seeing that there is something which is present again in the midline, right? And if you can see, this is the first image which is towards the right. You are seeing that there is a cystic structure over here. There is a cystic structure that is present in the midline, right? And what you are seeing, if I have put my color, I have put the color Doppler over here, you are able to see that there is some turbulent flow that is present in this cystic structure. So what is the diagnosis over here? Again, this is something which, okay, so really sorry for this. Okay, so what are the options? Arachnoid cyst, Dandy Walker malformation, vein of Galen aneurysmal malformation, porencephalic cyst. So what is the answer? Yes, Xavier, right? It is vein of Galen malformation. Gaurav, right again. Vein of Galen aneurysmal malformation. See, it is so easy, right? They can just show you the image. We have already discussed vein of Galen malformation so many times. We have seen the CT images, we have seen the ultrasound images, and they will just, if they want to confuse you, if they want to, just take some of more seconds from you, they can just show you this video. So no need to get afraid of this videos. This is something which you have already seen and they will just present it in the form of video, right? So this is your characteristic vein of Galen malformation, how you will see a cystic structure. If they have not put the color Doppler, it will look like a cyst. Now the question is, how will you differentiate it from the other differentials like arachnoid cyst, porencephalic cyst? So again, with arachnoid cyst and porencephalic cyst, you will never see color flow in it. It's only the vein of Galen aneurysmal malformation in which you will be able to see this color flow, because again it's a, no, what exactly is vein of Galen malformation? Because it's very important, I'm going to revise this for you. So what happens in vein of Galen? It is a misnomer, right? It is not actually an aneurysm. It is mainly because of the persistence of which particular vein? Median prosencephalic vein. It is going to fail to regress, and because of this there will be abnormal AV fistulas that will form, and because of this the vein of Galen which is there, it will not regress and it will become massively dilated because of the presence of multiple abnormal AV fistulas that are present, right? So the vein of Galen aneurysmal is actually nothing but a persistent dilated median prosencephalic vein. So if you see this particular diagram, again not diagram, an image, this is a CT angio image, and you can see that this is a massively dilated cystic structure, again a very vascular structure that is draining into the straight sinus posteriorly into the midline, right? Differential again for as we have already discussed the other options, any of the other cysts, again Dandy Walker cyst, it will be given in the posterior fossa rather than in the midline. They will give you posterior fossa, but again that will also not be vascular, right? So I hope this particular MCQ is clear. Yes, Xavier, right, it is a high AV shunt, right? Ricky is asking that how will you differentiate Dandy Walker? So again, Dandy Walker is, you will be given a posterior fossa. You will actually not be able to see the cerebellum also, because it is almost completely replaced by that particular cyst. Okay, so the completely it will be a different image only also. It is not vascular also. This vein of Galen aneurysmal malformation is a very characteristic image in which they will show you the color Doppler of a very high flow. So I would say that the best modality, okay, in which they will test you for videos is color Doppler, right? Color Doppler is one of the most important, I would say, investigations that could be tested apart from barium. Of course, barium can also be tested, and again wherever there is color Doppler, color flow, we'll see other pathologies as well in which they can ask you this videos, right? So again, some of the important points, important one-liners, because we have to revise also. Our focus is to have a little idea about how these radiology images could be tested, but again nothing of your base is going to change, nothing new is being added. It's just one and the same thing which we are doing, right? So nature, it's a congenital high flow AV shunt because of the persistence of the median prosencephalic vein. The presentation, as we have already seen in the question, how was the baby presenting? It was presenting with a large pericardial effusion. The baby is going to present with a neonatal high output cardiac failure, right? That is the way the baby is going to present. So these are the clinical hints which they can give you in the question to confuse you. The best screening method is of course your ultrasound, Doppler. Gold standard, of course, anything which is vascular, the gold standard will be always a DSA, right? What will be the treatment? The treatment is endovascular embolization. Common complication, why hydrocephalus flaca? Because of the obstruction, because something which is so large, it is going to, especially if it is present in the region of the third ventricle, posterior to the third ventricle, it is going to compress the aqueduct, right? And because of this, it will lead to an obstructive hydrocephalus. So that is how it is a very important complication. And as we have seen in this question, the baby was again presenting with hydrocephalus, and neonatal mortality causes heart failure, right? Okay, so let's move towards our next MCQ. Okay, so this is the third MCQ. Again, it's a very easy one. Again, by just seeing the, I would say, by just seeing the question, you can solve this. But again, it is important, and that is why I have included it in the form of video-based question. So the third question is, a 38-year-old man presents to emergency department with sudden onset severe left flank pain radiating to the groin. So with this, I am sure that you must know that this is a calculus, right? But let's see what is the question offering us. The pain is colicky in nature and associated with nausea and one episode of vomiting. Urine analysis reveals microscopic hematuria. Renal function tests are within the normal limit. Based on the ultrasound video shown, what is the likely diagnosis? Okay, whether it's a blood clot, whether it is a transitional cell carcinoma, whether it is a distal ureteric calculus, or whether it is a ureterocele. So let us just see this particular question. Okay, so let us just see this video. Okay, so what you are seeing, which I'm sure that you know that this is a calculus, but what is this artifact which we are showing over here? Okay, I'm replaying this video again for you. Okay, so what is this artifact? Everyone knows this. Okay, so can someone just point it out? Which artifact is this? That is not mentioned in the question, not mentioned in the answer as well. So you are able to see multiple colors, right? I have put the color Doppler over here again, and you are able to see multiple colors, red, blue, alternating type of color. So what is this particular artifact? This is nothing but the twinkling artifact. What is this artifact called as? This is called as twinkling artifact. Again, I will change the ink color. Okay, so this is nothing but the twinkling artifact. Okay, so why this actually occurs? So what is a calculus? Calculus is something which is very highly reflective. So if anything which is very highly reflective, if you just put the color Doppler over here, the machine is not going to perceive such a highly reflective. It is not going to perceive the ultrasound waves which are reflected back, and that is actually registered as noise. And this noise is nothing but the twinkling artifact, and you will see this alternating red and blue colors behind any highly reflective surface. Okay, it is not just limited to calculus. It can be also seen if there is a metal piece, if there is a foreign body, anything that is highly reflective. Suppose there is a suture material, right? These are all highly reflective surfaces, and they will show twinkling artifact. Now, the importance of twinkling artifact is, in a calculus, what happens? There is posterior acoustic shadowing. Everyone knows. In the gallstones, you have read about it. There is posterior acoustic shadowing. Now, why this happens? Because ultrasound waves are not going to pass behind a very thick, dense structure like a calculus. So, because of this, you will see posterior acoustic shadowing. But sometimes when the calculi are very small, you will not see posterior acoustic shadowing, and rather you will see this twinkling artifact. So I would say that twinkling artifact is much more sensitive than the posterior acoustic shadowing for small calculi. Okay, so that is the importance of this twinkling artifact. So with this MCQ, we have covered an important artifact of ultrasound, and of course we have now known that how to detect a calculus. So this is how we radiologists actually pick some small calculi, especially if it is present in the vesico-ureteric junction. These are very small calculi, and sometimes you are not able to see without putting the color Doppler. But once I put the color Doppler, and if I am seeing this twinkling artifact, I am very sure that there is a calculus that is present. How will a calculus look on a plane, on a normal B mode ultrasound? It will look like a hyperechoic appearance, right? So that is about this particular option over here. So the answer over here is a distal ureteric calculus. What other signs will you see whenever there is a distal ureteric calculus? You can always see there is a upstream hydrocephalus, right? There can be hydroureter. You can see periureteric fat stranding, especially if you are doing a CT. These are all the features that you will be able to see. Okay, now let's move towards again the initial investigation. If it comes to ureteric stones, it is usually an ultrasound rather than an abdominal X-ray. We prefer doing an ultrasound. That is a better investigation, initial investigation. Okay, absolutely free of radiation. But always remember your investigation of choice whenever it comes to renal calculi, ureteric calculi. It is always and always NC-CT KUB. Okay, this has been tested many times. Investigation of choice is NC-CT KUB. Twinkling artifact, again, it is more sensitive than posterior acoustic shadowing. Then the posterior acoustic shadowing, right? So I hope this particular MCQ is clear to you. Now let's move towards our next MCQ. So I will be showing you the question stem later on. Let's see the video first. Okay, I will just tell you that this is ultrasound of the scrotum. Okay, a person has come to you and he is come with severe pain, and we are doing ultrasound of the scrotum, and what you are seeing over here, let's play this particular video. Okay, so what are you seeing on your screen? Okay, so particularly this part, the initial part over here, what are you seeing? Can you see, can you appreciate that there is again some twisting motion, right? Again you can see that there is some twisting motion. We have put the color Doppler also over here, and you are able to see that the spermatic vessels, especially around the cord, they are all twisting around, right? So what is this particular sign and what is this particular pathology? Can anyone tell me? Okay, I will just show the question also. A 16-year-old boy presents to emergency department with sudden onset severe left-sided scrotal pain for the past 4 years. The pain was associated with nausea and vomiting. There is no history of trauma or fever. Based on ultrasound video shown, what is the most likely diagnosis? Yes, Xavier, very good. It is torsion, right? So this is a classical case of testicular torsion. What we have seen over here in this particular testicular torsion was that you have seen the characteristic whirlpool sign, because again the spermatic cord which is there, it is going to twist around, right, along the spermatic vessels, and because of this you will appreciate this very classical whirlpool sign of the testicular torsion, right? So this is one of the signs again. So we have covered 2 Whirlpool. I'm sorry if you are not able to see this particular thing. I will give you the annotated PDF again. But again, I'm just repeating that Whirlpool sign we had seen in the first MCQ also in the cases of midgut volvulus. And again, we are repeating what? We are seeing this testicular torsion. We are again appreciating this classical Whirlpool sign because of the twisting of the spermatic cord, right? So this is how they can test you for testicular torsion. I have got one more video, so you can see this video again. Okay, can you see this particular video? You can see that how well the spermatic cord, you can see this, that it is twisting around, right? I hope that you are able to appreciate this particular thing. Yes, Ankit, right? It is C. So Whirlpool sign, I would say that it is the most specific sign. So when it comes to testicular torsion, it is the most specific sign that you will be appreciating in testicular torsion. Now, what are the other ultrasound features that you will see when it comes to testicular torsion? What will happen? Of course, there is a decreased vascularity. In the main testis parenchyma, there will be decreased vascularity. So you will not be able to see the color flow on the testis. So again, they can show you a video in such a manner that they will show you this Whirlpool sign, and they can focus on the testes in which there will be no flow. So that is how they can show you the testes overall. Normally it is a very homogeneous type of a structure, but when it comes to torsion, it becomes very heterogeneous, right? It becomes, sometimes you can also see hematoma within it, right? So all these particular things can be again shown to you in a testicular torsion. Okay. So let us now move towards again the gold standard treatment when it comes to testicular torsion. Just a quick revision. We all know that immediately once, even if the clinical suspicion is very high, you will immediately go for a surgical exploration and orchidopexy. The salvage rate is within 6 hours. So if within 6 hours, it is approximately more than 90%, but after 24 hours, the salvage rate is going to decrease. So again, whenever there is a clinical suspicion, if the patient is coming to you, then you have to immediately go and refer this particular patient to a surgery. Now, one important point I would like to stress is that partial or early torsion, they may still have some initially arterial flow. So initially the venous flow will go, and then later on the arterial flow will go. So even if you are seeing this Whirlpool sign, but sometimes some flow may be preserved in the testes. So don't think that this cannot be testicular torsion, right? In the early phases of the torsion, some arterial flow can still be preserved. So if there is Whirlpool sign, that is the most specific sign, plus acute scrotal pain, then it is torsion until it is proven otherwise, right? So Xavier, you are asking me that how do we know that patient is having the initial investigation should be? It's nothing like that. Even in the government setting, we are now approaching for the patient who is coming with severe pain. We actually start doing with ultrasound also. It's not like, so ultrasound is also very affordable. It can be done in the government setting. I think I didn't get your question very well. But for ureteric stone, yes, we do ultrasounds only, right? We can pick at least the secondary signs. They can be picked very well on the ultrasound. Like hydronephrosis can be very well seen on an ultrasound. So we do an ultrasound only as an initial investigation. Ultrasound is, I would quote ultrasound better than that of X-ray KUB as an initial investigation. So if two options are given to you, pick your answer as ultrasound KUB as an initial investigation, right? So let's move towards our next question, and I am sure that everyone knows this particular MCQ. I am first going to display the video for you, and then I will read the question. So what is this classical sign? Okay, everyone has seen the image. Now we have showing you the video. So this is one of the videos which I was very fascinated by. I was, I think, in my residency, I was an R1, and I had captured this video, and I'm so glad that I'm able to share this video today. So this is a very classical, if someone has written. So there is usually a lag. When I ask you, there is, I think, a lag of 1 minute, and that is why I get the answers little late. So this is a classical Pepsi sign, right? So this is a Pepsi sign. Okay, so what is the question that they have given? A 62-year-old undergoes transfemoral arterial catheterization for coronary angiography. 3 days later, he presents with painful swelling in the right groin. So again, this is very classical pseudoaneurysm, and you are going to see this classical Pepsi sign, or also called as the Yin-Yang sign. So the answer is femoral artery pseudoaneurysm. So what happens in the femoral artery, and why you are able to see this particular Pepsi sign? So if you can just appreciate, I'm really sorry for this pen. Again, you can see that whenever there is, supposing in this case there was a femoral artery, okay, because the catheterization has been done. So what you are seeing over here is that the adventitia which is there, it is going to damage, right? Because of the invasive procedure, the adventitia is damaged. Because of this, there is an outpouching that has developed, and there is a pseudoaneurysm that has formed. Now what is going to happen when I am going to put my color Doppler over here? What you are able to see, so during the systole, the blood is going to enter into the sac, and during the diastole, the blood is again going to come back into the main vessel. Now, if I am putting my probe over here, what is going to happen? The probe is going to detect two flows. It is detecting bidirectional flows. So, whenever the blood is going towards the probe, it will be displayed as red. If it is going away from the probe, it will be displayed as blue. So, this is exactly what is happening over here, and that is why you are able to see this Pepsi sign or the Yin-Yang sign of the pseudoaneurysm. I hope this is clear to you. Again, this is one of the classical ultrasound images, again using Doppler, and this could be tested in the form of video, right? I hope this is clear to you. So, you know the mnemonic BART, right? B-A-R-T, blue away, red, and red is towards. It's not okay, venous means blue and the arterial flow means red on the color Doppler, right? It's again depending upon the direction of the blood flow, you will be able to appreciate this blue or red color. Blue is away and red is towards the probe, right? Now, if you just see over here, you can see this biphasic type of flow over here. Right, again this is the spectral Doppler image. So, for the same pseudoaneurysm, you will get this type of a biphasic type of a flow, right? One flow you can see it is above the baseline, one is towards the flow, because again the directions have changed because the blood is entering in the systole and then again it is leaving in the diastole in the pseudoaneurysm. So, you will get this classical spectral Doppler waveform also. How will you manage this? Someone wants to write, how will you manage this particular pseudoaneurysm? You usually they do what? They do a ultrasound guided thrombin injection. Okay, they can inject thrombin or they can just do a compression. Okay, they can do compression. If it is not managed with this conservative management also, then what they will do at the end, they will be doing an endovascular management of this particular aneurysm, right? So, this is about this particular Pepsi sign. Now, let's move towards our next MCQ. So, this is the 6th MCQ and I will just read the question first and then I will show the video. A 26-year-old primigravida undergoes a routine anomaly scan at 20 weeks of gestation. Maternal serum screening performed earlier in pregnancy, it revealed a relatively elevated AFP. So, this is an important hint they have given that there is an elevated AFP, right? So, if you talk about she has no history of diabetes or teratogenic drug exposure based on the fetal ultrasound video, what is the most likely diagnosis? Whether it is gastroschisis, whether it is myelomeningocele, congenital dermal sinus, or whether it is an omphalocele. So, let us just see this video and try to identify which anomaly they have shown. You see, AFP will be elevated in all of these, right? Because whenever there is any defect that is present either in the spine, whether it is a ventral wall defect, your AFP or alpha fetoprotein will always get elevated. So, it is important that you have to identify whether there is a spinal defect or whether there is a ventral defect, right? So, let's see. So, what you are seeing over here. Okay, so this is a sagittal cut through the antenatal scan of the baby and you are able to see that there is a cystic structure that is present posteriorly. Now, how I have identified that this is something which is posterior, you can see this hyperechoic areas over here. This is nothing but the spine of the baby. So, bones, they will always look hyperechoic, highly reflective structures. So, the bone, the spine, it is going to appear very bright, right? Now, in this particular area, you are seeing that there is a defect. There is a cystic area that is present. This cystic area, it is looking like that of fluid only. Now, what is going to come out of the spine? It is your CSF, right? So, this is your myelomeningocele that is happening. You can also see that there is some neural tissue that is present over here, right? So, this is meninges plus there will be also some CSF that is present along with the neural tissue, that is nothing but your myelomeningocele. So, this is a classical case of myelomeningocele. Right, so yes Xavier, right. So when I talk about omphalocele, I will be showing you the images of omphalocele also. So right, there will be a covering that is present, whereas in gastroschisis, the covering which is there, it will be absent. I will be showing you just in a moment the view, and I will be showing you the images of gastroschisis and omphalocele. But like the myelomeningocele videos, they can also show you the videos of omphalocele or gastroschisis, right. So let us just see this particular image. Now, what is the first image? Okay, so this is image number 1, this is image number 2. Tell me which of the following is omphalocele and which of the following is gastroschisis. Let's focus on the first video over here. First of all, try to identify again, this is antenatal and this is the abdomen of the baby. Okay, we are taking like axial sections. If you just see, this is the abdomen of the baby and you are able to see that there is some freely floating structures that are present over here. Okay, so this is nothing but this is gastroschisis. There is no membrane also that is present around. This is gastroschisis. Okay, whereas if you see this particular structure over here, there is a membrane. I am not sure that you are able to see it, but actually there is a very thin membrane that is present. There is a thin covering that is present. So that is omphalocele. In omphalocele, usually what happens, apart from the bowel, there will be also herniation of the tissue. Like for an example, in this case, there was herniation of the liver as well. So this second image which is there, it is the case of an omphalocele. Okay. Okay. So Xavier is telling that skull नहीं पता चल रहा है because skull मैंने दिखाया ही नहीं है, right? I have not shown you the skull. This is, if you see this particular video, this is actually at the lower level. This is just the lower level, at the level of the spine which I am showing you. This is a sagittal image. Okay, it is very easy to identify the spine. Spine तो समझ आ गया ना? Spine, how do you see the spine? You will see this hyperechoic multiple bones, right? That is spine. Okay, और तो कोई body organ में ऐसा hyperechoic appearance नहीं होगा. And then what you are seeing, this particular defect over here. So this is very easy to crack, I think. That is not problem. Okay, so right. Okay, so let's move towards our, what are the other signs that you can see with myelomeningocele? So they can again classically club these particular signs with the myelomeningocele. So the first image, again these are the fruit signs. So what you are seeing over here, you are able to see the scalloping of the frontal bones. Which particular fruit it is resembling? This is nothing but your lemon sign. Okay, this is the lemon sign. This is again classically seen with myelomeningocele because again the pressures are going to decrease because CSF is leaking, and that will lead to this particular scalloping of the frontal bones. What about the second image? You are able to see the very classical banana sign. Okay, so what happens over here? So this is again classically associated with Arnold-Chiari type 2 malformation. So there is even, what happens? There is a small posterior fossa. There is herniation of the brainstem and the cerebellar vermis. So because of this, there will be curving of the cerebellum. Again, because of the downward pull that has been created in the posterior fossa, this will lead to the curving of the cerebellum, and that will give rise to your classical banana sign. Okay, so these are the two important signs. Because we were discussing myelomeningocele's video, these two signs will always come together, that is lemon sign and banana sign on the antenatal ultrasound, right? So yes, Sonal Rupika, right, it is first image is the lemon sign, the second image is banana sign. Okay, now let's move towards our seventh question. Again an ultrasound. So the chance, I have shown you a lot of ultrasound images because I feel that if they will be testing you in radiology video based questions, it will be mostly, it will be either an ultrasound or a Doppler image rather than a scrollable CT or a MRI image, right? So let us see the question first. A 42-year-old woman presents with recurrent episodes of right upper quadrant pain, especially after consuming fatty meals. The pain lasts for 1 to 2 hours and it is associated with nausea. She is afebrile and laboratory investigations are within normal limits. Based on the ultrasound video shown, what is the most likely diagnosis? Whether it is a polyp, whether it is carcinoma, whether it is simply cholelithiasis, or whether it is a biliary sludge. So let me just show you the video. Okay. So what you are seeing over here is, first of all, you need to identify how the gallbladder looks. Okay, so the gallbladder, it looks like this, right? This is a normal gallbladder. It looks like an anechoic structure, an anechoic bag-like structure, and this particular structure over here is your liver, right? So gallbladder, it is very important you identify the gallbladder. Now once you are identifying the gallbladder, again I am just playing this video for you. What you are seeing, that there are some hyperechoic areas that are present in the gallbladder, right? Now what are these particular hyperechoic areas? I am going to replay this again and then I am going to pause this for you. So what you are seeing over here is this classical sign. We have already seen the twinkling artifact, right, in the initial MCQs. Now what is this particular sign? You have seen this image multiple times and thus this image has been shown to you in the former video. You are seeing that there is a hyperechoic structure. Hyperechoic means there is calculus, right? It is highly reflective structure, so that is why it is appearing hyperechoic. But because it is again highly reflective, what you are seeing, you are able to see a lot of shadowing behind this particular calculus. This is nothing but your most favorite posterior acoustic shadowing, and this is a classical case of cholelithiasis, right? So this is a very simple case. Normal cholelithiasis I have shown you. Gallbladder is there, calculus is there, posterior acoustic shadowing is there. Remember that for the gallstones, investigation of choice is always ultrasound, because what is the composition of the gallstones? It is made up of cholesterol. Will you be able to see the cholesterol stones on NCCT? Very less likely. So the only place where ultrasound is better for calculi, it is gallbladder. So cholelithiasis mein investigation of choice is always ultrasound. So these are some important points which I have told you about cholelithiasis. Now again I am telling you that this is a very simple image. They can show you something like this. I mean that the wall, okay, you can see that the wall over here is very thin, it is very smooth, but they can show you a very thickened wall. They can show you a striated wall along with these calculi. In that case, you will mark your answer as acute cholecystitis. Again, I will be showing you the image. I have the image with me, so I will show you, but they can show you in the form of video also. If the wall is thickened, then it is not just simply cholelithiasis, it is acute calculus cholecystitis, right? Okay. So let us now move towards our next image category. You can see that, so the answer in this particular case is simple cholelithiasis, right? Answer over here is C. But there are 4 important images, and all these 4 images which are present on your screen, they can show you in the form of video, okay? Gallbladder, so you know how to identify. If you are able to identify this 4 to 5 pathologies of gallbladder, almost all the videos you can crack, right? So the first one, you can see this we have already shown you. This is the posterior acoustic shadowing behind the calculus, right? So there is cholelithiasis. But if you see the wall over here, okay, I will just zoom this for you. If you see the wall over here, this wall which is there, it is little thicker, okay, as compared to the video which I have shown you. This wall is relatively thicker. So the first one, it is your cholecystitis. The first case is a calculus, acute calculus cholecystitis, right? So that is our first image, right? Okay. Now if you talk about the second image over here, okay, what you are seeing over here, okay, I will just show you this image first. This is relatively easier. What you are seeing, again you can see that there is presence of the gallbladder, and what you are seeing over here is that there is some low level echoes that are present, okay? Can you see this? Again, I am zooming this for you. You are able to see that there are some low level echoes that are present in the gallbladder. This is your simple gallbladder sludge. This is gallbladder sludge. If you are seeing this dependent low level echoes, that is gallbladder sludge. See, one more important point regarding calculi is that they are mobile. Okay, that is how you are able to differentiate the calculi from other pathologies, because calculi are very mobile. So even sometimes if I am confused, I will ask my patient to turn prone on the table, and if the calculi are moving, I am very sure that along with posterior acoustic shadowing, the calculi are also mobile. Even sludge, for that matter, it is mostly present in the dependent part, and it is also mobile. Right? Now if you see the third image over here, what you are seeing is that there is something which is present again in the gallbladder, in the fundal region, and if I am putting my color also over here, it is showing that there is some color, some Doppler, some vascularity that is present in this area. So this is nothing but, this is your gallbladder carcinoma. Okay, so this is your gallbladder carcinoma, and this is how they can test you for a gallbladder carcinoma, in which they will show you a solid appearing mass that will be also vascular. So that is your gallbladder cancer. Now if you see this particular image, okay, the fourth image, okay, anyone wants to guess what is this fourth image? I am telling you that there is a hyperechoic area. Can you see any posterior acoustic shadowing? There is no posterior acoustic shadowing over here. Right? Now, what is this particular thing? Xavier, third is GB carcinoma. Knees Halini, yes, polyp is not mobile. Rest. So, right, this is actually a polyp. So, polyp is not mobile. So, they can give you a hint. If they have not shown you a video, they will tell you that you are seeing some hyperechoic area that is not mobile, that is present along the wall. It is not mobile. They can again show you a video also, and there is no posterior acoustic shadowing which you see in a highly reflective surface like calculus. So, that is how you will differentiate from the GB polyp, right? So, the answer over here is GB polyp. So, these are the 4 important gallbladder pathologies. Actually, we have covered 5. A simple case of cholelithiasis, which I have shown you in the form of video. Then the first image over here is a calculus cholecystitis. You can see a thickened wall. Okay, in the second image, you can see that there is low level echoes. This is the second image. You can see there is gallbladder sludge. The third image, you can see a solid appearing mass with vascularity. That is a gallbladder cancer. And the fourth image, you can see a hyperechoic area along the wall. No posterior acoustic shadowing is present, and it is absolutely non-mobile. So that is a gallbladder polyp, right? So that is about this particular thing. Now let us move towards our next question, that is, again it is something related to the obs part. So let us see this question. A 29-year-old woman presents to the emergency department with lower abdominal pain and spotting per vaginum for the past 2 days. She reports 7 weeks of amenorrhea. Urine pregnancy test is positive. Serum beta HCG levels are elevated. On examination, there is a mild adnexal tenderness. Okay, so there is amenorrhea, there is pain that is present. Okay, and of course, the beta HCG levels are elevated. There is adnexal tenderness. Based on the ultrasound video shown, what is the most likely diagnosis? So let us just see this video. Yes, knees, yes, it is ectopic, but let's see the video first. Okay, so let us just see the videos. It's a very small video. you are able to see that there is again a cystic structure that is present. My probe is present somewhere in the adnexa. Okay, somewhere it is present in the adnexa apart from the uterus. I am telling you that there is nothing which is present in the uterus. Okay, there is no gestational sac present in the uterus. In the adnexa, I am able to see that there is a G-sac like structure. You can also see some fetal part over here, and you are able to see this very beautiful ring. This is nothing but your, what is this particular sign? Can someone tell me this particular sign? I want someone to write what is this particular sign. This is the most easy one. Ring of fire sign. Okay, so this is your ring of fire sign. So the answer over here is tubal ectopic pregnancy. See here in this question, the clinical hint is very clear, right? There is presence of amenorrhea, there is bleeding also that is present. The patient is, in short, I would say, a very symptomatic type of a patient who has come to you, right? So the answer over here is very easy, that this is the ring of fire and this is tubal ectopic. Now the other options are corpus luteum cyst, hemorrhagic cyst and endometrioma. Okay, so what other pathology will also show ring of fire sign? So that is your corpus luteum cyst. So how will you differentiate whether you are being shown a corpus luteal cyst, right? So they will always give you some clinical hint first of all in the question. So when do you see a corpus luteal cyst? It can be in a physiological form, or they will give you a normal pregnant patient in which the sac, the G-sac will be present intrauterine, and if you are seeing a cyst that is present in the ovary itself, right, and that particular cyst, it will be also having some very crenulated type of margins. I will show you the image also. So crenulated margin cyst, okay, either in a asymptomatic patient or a normal pregnant patient, especially in the first trimester, you know that there is a corpus luteum that is going to develop, right? So in that cases you see the corpus luteum cyst. So always look for what are the clinical hints that are given to you in the question. So corpus luteum, again, if a cyst present within the ovary itself, that is usually a corpus luteum cyst. Whereas if I talk about a tubal ectopic pregnancy, more likely they will show you a fallopian tube. I mean, they will be showing you a separate ovary from it, and you will see this particular ectopic pregnancy somewhere along the tube, right? Yes, Xavier, hemorrhagic ovarian cyst will have a fishnet appearance, and endometrioma, what will endometrioma show you? It's a chocolate cyst. It will show you some low level echos. So I will show you the image. First of all, first image, again you can see over here the classical ring of fire appearance, right? Now, but over here what you are able to see, first of all, this particular cyst, it has got very crenulated type of margins. Patient over here is asymptomatic, or again the patient is having a normal intrauterine pregnancy, maybe in the first trimester, and if they are showing you such a type of image, this is your normal corpus luteal cyst, right? Okay, now let's move towards our next image over here. Okay, so what about this particular case? First image, what you are seeing over here, you are seeing some low level echos. Okay, you can, I will just zoom this for you if you are not able to appreciate. You are able to see very low level of echos. Again, they will give you some classical history pertaining to endometriosis. Maybe they will give you a history of dysmenorrhea, right, especially during the menses. And this classical appearance of low level echos, this is nothing but your chocolate cyst or the endometrioma. Okay, I will annotate and upload the PDF soon after the class. And what about this particular image? This is a very classical fishnet appearance. So this second image which is there, can someone tell me what is this classical fishnet appearance or reticular appearance? Again, patient may present, a young patient, they may present with pain, adnexal tenderness may be present, but it has nothing to do with the pregnancy. It's quite physiological. It's hemorrhage that happens either in a corpus luteal cyst or in a simple follicular cyst. You will get this classical fishnet appearance. Okay, so this is your classical. Yes, Shiva, right? It is ground glass appearance. So good, you pointed it out. The first image, the low level chocolate echos, that is also sometimes called as a ground glass appearance in endometrioma. The second is the fishnet appearance, and that is very characteristically seen for hemorrhagic cyst. Yes, Nizhalini, right. So I'm sorry if I'm not pronouncing it right, but right, it is hemorrhagic cyst. Okay, now let's move towards our 9th MCQ. Again, this is very high likely that if any video comes from radiology, they can show you this particular image. So please concentrate. This is a very important video. I'm giving you the question. A 58-year-old woman presents with acute onset swelling and pain of the left lower limb for the past 3 days. She underwent total knee replacement surgery 2 weeks ago and has been relatively immobile since then. Okay, see, I am very generous. I have given everything pertaining to this particular pathology in the question. Your examiners might not be this, they may not be so easy on you. They may not give you so many clinical hints in the question, but my point is that any of these one clinical hints can be given to you along with the video. So that is why I have included all the points in the question. On examination, the left calf is swollen and tender compared to the right side. Based on ultrasound video shown, what is the most likely diagnosis? So with the clinical question, you know that we are mainly discussing about deep vein thrombosis, right? So you know this, right? Sometimes they will not give you this clinical question, they will just give you this video of the groin region. So my probe over here is in the groin, and I'm just going to display this video to you, what you are seeing over here. Okay. So what you are seeing over here is, can you see that there is some echogenic structure that is present over here in the vein? Okay, so medially usually the vein is present. Okay, so they might, so when they will show you this inguinal region, they might be generous enough to at least mention right or left. Okay, medially the structure that is present, it is usually a common femoral vein. You can also identify by the great saphenous vein that will be draining in through the common femoral vein, and of course this particular structure laterally which is there, it will be your common femoral artery. Now you are able to see that there is a echogenic structure that is present in the common femoral vein, and in this particular video, unfortunately I didn't have the Doppler image, but they can also show you a color flow, and there will be no color flow in this particular region. So this is your classical case of, yes Ricky, this is your classical case of deep venous thrombosis. My point over here is to at least you should identify, either they can give you a plain image or they can give you a video image. Now what I am doing in this particular video is I am compressing this area. I am compressing my common femoral vein. So normally your common femoral vein is compressible. Okay, venous structures, they are compressible. But if the thrombus is present, what is going to happen? It is not compressible. So what I am testing over here is, I know there is a thrombus, but I am testing over here for compressibility. So remember that there is a non-compressible vein that is present. So this is a classical case of deep vein thrombosis, right? So this is, I think there is no need to even see the other MCQs, other options over here. It's quite straightforward that they can test you for a DVT in a form of thrombus and by showing you a compressibility video, right? So investigation of choice, whenever you are suspecting DVT, especially initially when the patient is going to come to you, it is always your Doppler ultrasound. It is always your Doppler ultrasound. That is the initial investigation. And if I'm talking about if the patient is having a suspected pulmonary embolism, right, D dimers are elevated, the patient is presenting with dyspnea, some sort of history that they are suspecting pulmonary embolism, my investigation of choice will be always CT pulmonary angiogram, right? You have to do a CT pulmonary angiogram. That is the best investigation to rule out your pulmonary embolism, right? So I hope this particular MCQ is clear. If there are any doubts, you can put it in the chat box, and I'll try to solve your questions if you have any questions. Yes, Xavier, right, it is CTPA. Now moving towards our 10th question, again a very high yield video. I have included almost all the high yield videos for you. So it's a very useful session for you, and of course I will also try to accommodate more videos, and I'll upload it on the app. So, a 19-year-old man presents with abdominal pain that initially started around the umbilicus and later migrated to right iliac fossa. Again, a very straightforward history, umbilical pain radiating towards the right iliac fossa. Laboratory investigation shows leukocytosis, neutrophilia. Based on the ultrasound video, what is the diagnosis? So, Xavier is writing already that the answer is acute appendicitis, but see other options also. It is not always that they will show you acute appendicitis. It can be mesenteric adenitis or Crohn's disease involving terminal ileum or acute cholecystitis. So acute cholecystitis, we have already seen that particular video. We know how gallbladder looks like, how the calculus look like, how cholecystitis will be shown you in the form of a thickened wall, right? So this is not acute cholecystitis. Now I am going to play this video for you. What you are seeing over here, you are, again my probe over here, it is in the right iliac fossa. Okay, I am mentioning this, sometimes they will not mention, and this is very classical spotter image. Okay, what you are seeing a very beautiful tubular elongated structure, and at the end part what is happening is that this is the cross section of that tubular structure. So you are getting almost like a target appearance, right? So this is nothing but your inflamed appendix. Okay. So again I am showing you this video. You are able to see that there is a tubular structure, an elongated tubular structure, and you can see that this is how the wall is looking like, right? It is looking very striated, it is looking very thick, right? And again I will be using over here, okay, so So if I'm just compressing, if I'm just showing you a compression video also, I can show you, this will be not compressible, okay. As DVT we have seen, DVT is also non-compressible. Similarly, a patient with acute appendicitis, appendix becomes non-compressible. So they can show you graded compression video. They can show you this tubulus type of a structure that will be again very much thickened. What is the criteria? What is the diameter criteria? So it is more than that of 6 mm. That is the main criteria, right? And of course, if they will show you, sometimes they can show you a CT image also. They can show you an associated appendiceal fat stranding, okay. The adjacent mesentery which is there, it will appear very dirty whenever there is an acute appendicitis, and this is non-compressible, right? So this is about this particular video. Again, acute appendicitis, especially when it comes to pediatric patients, your initial investigation, or actually your investigation of choice in the pediatric patients, in the pregnant patients, it is usually an ultrasound, right? But for an adult patient, especially if you are suspecting that there can be some complications, like there can be an appendicular abscess, okay, there can be a perforation, in all that particular cases, your investigation of choice will become a CECT abdomen. Right, so that is about this acute appendicitis. Now let's move towards our 11th question. This is the last second question. A 24-year-old primigravida undergoes a routine first trimester anomaly scan at 12 weeks. So we are only in the early trimester at 12 weeks of the gestation. Maternal serum screening performed earlier showed a markedly elevated AFP. So again, there is an elevated AFP. We have already seen one MCQ with elevated AFP. There is no significant medical history. However, the patient did not receive periconceptual folic acid supplementation. So they have given you some hint that it can be because some neural tube defects can be present. AFP is elevated. Folic acid has not been taken. Based on the fetal ultrasound video, what is the most likely diagnosis? So let me just show you the video first. Okay. So I will just... Okay, so what you are seeing over here is, you are seeing the head of the baby, okay. Can you spot one classical sign of the head of the baby? Okay, I am not sure whether this will be easy one for you, but let us just replay this video again. What you are seeing over here is again a very classical appearance, which we have discussed in the images. Now and then we have discussed this. Yes, Ricky, this is anencephaly, right? So what happens over here, what imaging, so I will just pause it over here at this particular point. See this particular appearance over here, you can see that this is the mid-coronal section of the baby's head. Okay, this particular part, okay, I'll just zoom it, I'll just pause it over here. Okay, especially this particular part, right? So what you are able to see is that the absence of the calvaria. Okay, what happens in anencephaly? There is absence of the calvarium just above the level of the orbits, right? Because the calvarium is absent, what is happening? The orbits which are there, they are the globes which are there, they are protruding. This appearance is called as the frog eye appearance that you will see in the anencephaly. Yes, Puneet, Shantanu, right? It is the frog sign. So this is the classical history. So this is one again, this has been tested many times in the form of images. Again, they can just show you the video. So this will be a little tough one, I would say, as compared to the other MCQs, because you have to see for the entire thing. And actually there is no cranium. So if you just try, I will just try to take it over here. At this particular level, what happens is that normally you should be able to see a skull. Okay, you should be able to see a hyperechoic appearance. Can you see this particular part? This is hyperechoic because this is bones. Okay, so normally a fetal skull should be seen. In this particular case, there is no fetal skull only that is seen in this particular area. Okay, you cannot appreciate any particular fetal skull in this area. It's just this soft tissue that is present, which is nothing but your protruding brain tissue. Now, what other sign? Apart from the frog sign, we have also got one classical sign. Okay, what happens if there will be protruding brain tissue, especially it will be protruding laterally when the skull is absent? What classical sign you will get? Please put it down in the comments. What is the classical sign that you will get? Apart from frog sign, we can get one more sign. I'm waiting for a couple of seconds. So the answer over here is anencephaly, and okay, so you get the classical Mickey Mouse sign. Okay, I didn't get any answers, but this is a very classical hot favorite question. Apart from the frog eye sign, you can get the Mickey Mouse sign because it resembles the Mickey ears when the protruding brain tissue will be seen in the whenever the skull will be absent. So that is the second sign. Okay, now what about... No, it's Shantanu, it's not lemon or banana. Lemon or banana we have already discussed when we were discussing the myelomeningocele, right? So let us now talk about the next best step. So whenever the anencephaly is suspected, first of all, when you will detect it, it is one of the first anomalies that is usually detected. So you will detect it at around 11 to 14 weeks. Okay, you will detect it at around 11 to 14 weeks in the early trimester. The next best step is we have to abort the baby. Okay, this is absolutely, the baby will not survive, right? It is non-compatible with life, and the next best step you have to advise over here is, so they can just show you this video and then they can test you what is the next best step. The next best step is to abort the fetus, right? Now, what about AFP, as I have already discussed in many of the other pathologies which we have already discussed. Here also, because the brain tissue is exposed, you will always have an elevated AFP. Yes, Ricky, very good. Mickey Mouse also seen in the saphenous vein. Yes, and Mickey Mouse is also seen in two other pathologies. One, it is seen it in the Hutch diverticulum. Okay, in the IVP you will see this paraureteric diverticulum. There also you will see the Mickey Mouse sign, and you also see the Mickey Mouse sign when we are imaging the POTA. Ultrasound pe POTA, it will also look like that of a Mickey Mouse. So we have actually 4 Mickey Mouse when it comes to radiology. One is in the anencephaly, and that is the most common tested one. Normal appearance of the ultrasound in the inguinal region of the common femoral vein, artery, and the great saphenous vein, that will also give you the Mickey Mouse sign. Normal appearance of POTA will give you the Mickey Mouse sign, and Hutch diverticulum will also give you the Mickey Mouse sign. So these are the 4 Mickey Mouse which we cover. I also remember one more Mickey Mouse sign. It is seen in nuclear medicine in the Paget's disease. In the Paget's disease, because the uptake is present in the spinous process and in the bilateral vertebra, if you do the bone scan, there also you see the Mickey Mouse sign. So we have 5 Mickey Mouse sign which we have covered, right? So yeah. So let us now talk about the elevated AFP. I have already told. Now what happens to amniotic fluid when it comes to anencephaly? Will it be increased? Will it be decreased? Okay, this is again an easy one. What will happen to the amniotic fluid? If someone wants to write it down in the comment, I will wait for 5 seconds. Actually, there is a lag. When I ask the question, there is usually a lag of 1 minute, and that is why I move ahead and then the answers come later on. So the amniotic fluid will increase. When it comes to anencephaly, there is always polyhydramnios. Yes, Ricky, I remembered 5 signs, 5 Mickey Mouse signs. I am also astonished that I remembered 5 Mickey Mouse signs, right? So the amniotic fluid will be increased when it comes to, now why in anencephaly there is polyhydramnios? So why the amniotic fluid? So the why is important. It is mainly because again the brain is not functioning properly. The baby is not able to swallow, right? Because that swallowing is affected. That is why you will be able to see the elevated amniotic fluid, right? So the swallowing is apart from this, if there is any pathology pertaining to say esophagus, like esophageal atresia is there or duodenal atresia is there, in all those cases also you will see elevated amniotic fluid, right? So yes, Xavier, right, it is increased. Now let us, this is an easy one. This is the last MCQ which we are discussing. Okay, so this first image, I am just going to zoom this for you. So what you are seeing over here, okay, what is this investigation? So this is a easy peasy. Please tell me in the comments, what is this investigation? I am replaying this for you. Again. So what is this investigation? Can someone please write it down in the comments? Yes, Xavier, in the previous MCQ, the absent cranial vault is diagnostic. Yes, Ricky, it is barium swallow. Kunal, it is not barium meal, this is barium swallow actually which we are doing over here. And now tell me whether it is normal or abnormal. So the students get confused whether this is normal or abnormal. Here the person, we have given him the barium, we have made that suspension and we have asked the person to swallow the barium, and he has very well gulped the barium, and we are doing it, we are imaging it in the live fluoroscopy, right? This is absolutely a abnormal or normal? Can someone tell me? This is a absolutely normal barium. Okay, this particular, some of them may get confused. What is this brackish area that you are seeing? That is nothing but air. Okay, the patient along with barium, he has also taken some air, so that is what is being seen. So this is an absolutely normal barium swallow. Now why I have included this? First of all, they can ask you other investigations in the form जहाँ पे भी fluoroscopy होगा. Like for an example, they can show you barium meal in which there will be again, apart from esophagus, the stomach which is there, it will be also coated with barium. So that is how they can tell you. The first MCQ which we discussed, right, the corkscrew appearance, where we have discussed the where we have discussed that there was the twisting that was present of the duodenum as well as of the jejunum, right? What we have seen, so that again they can show you in the form of a upper GIT contrast study in the cases of midgut volvulus. That is how they can show you. They can test you for intussusception in the form of video, in which you will see an abrupt cut off, a claw sign wherever there will be an intussusception that will be present. Now, most importantly, how they can test you is corkscrew appearance. Where will you see the corkscrew appearance? The image, you all know very well how a corkscrew esophagus looks like, right? You will see this multiple constrictions. Where will you see? You see it in diffuse esophageal spasm. Unfortunately, I didn't have that video. I'll try to arrange for that video. But again, you can see this is a normal barium swallow. They can show you multiple pathologies on the form of barium. So this is ultrasound and barium. These are the two important modalities I feel that they could be tested when it comes to your video based questions, right? They can again show you a esophageal carcinoma, in which you will see this rat tail appearance, some irregularity. Then they can show you achalasia also, right? What happens in achalasia? You will see the sudden tapering, a bird beak appearance, so that they can show you in the form of video. They can show you a feline esophagus, where you will see eosinophilic esophagitis, right? So I'm just revising some important barium images with you. This barium images, they can be tested in the form of videos also. So this is how they will take you. Mostly they will test you some dynamic investigations like barium I have already talked to you about. They can show you a ERCP image in the form of video, and then they can tell you that identify the investigation. Most important, most novel, they can actually show you MR defecography, in which the patient is actually asked to defecate on the table itself, and then they will be showing you this rectum and sigmoid, and they will just tell you that what is this investigation going on. So of course, whenever we will be doing a next session on the video based questions, I will include whatever we have not covered today. There are n number of videos that can be made from almost all the images, right? Our point of focus is we do not have to increase our resources. Jo pada hai, we have to just do that only. The point of this video is to make you aware that what you already know in the form of images, that could be tested in the form of videos. In this 12 questions, tell me that if any of the questions you didn't know, knew everything. It was just that the presentation has changed in the form of video. So nothing to get worried about. Okay, you will be getting an extra time also to solve these particular questions, and I think it will be easy one to crack for you. So it will be, the difficulty level will be same for every one of you, right? So and of course they can also test you some classical pathologies of barium, which we have already discussed. So if you have any pertaining doubts pertaining to these video based questions, you can, okay, so if you have any doubts, you please put it in the chat box and I'll try to answer. But this was all about this session, a quick session just to orient you how radiology can be tested in the form of video based questions. We will definitely upload more and more videos in our question bank, and you will be definitely enjoy doing those videos. If you have any questions. Okay. So I think we do not have any questions. So I wish you all the best and good night.